Hello everyone, I am going to show laparoscopic Nissens fundoplication. This patient has got a large hiatus hernia with a severe esophageal injury. So we have got the exposure already. We are entering into the lesser sac by dividing the gastrohepatic ligament. And once you divide the gastrohepatic ligament, you can appreciate the caudate lobe of liver and the right crest which is coming into view. Hold the right crest of the diaphragm with your left hand, and the assistant will retract the esophagus on the left side. That will give some traction, counter traction in order to enter into the space between the esophagus and the right crest. So if you want to enter into the space between the esophagus and right crest, you have to divide the phrenoesophageal ligament. Once you divide the phrenoesophageal ligament, you will enter into the space. Sometimes in case of severe esophagitis, it can get some peri-esophageal fibrosis which needs to be lysed carefully, and we are extending our peritoneal division on the anterior aspect followed by division of the phrenoesophageal membrane. While doing this, we have to protect the anterior vagus from the injury, and again with traction and counter traction, try to place all the adhesions between the esophagus and the periesophageal structures, so that you will be able to bring a good length of esophagus intra-abdominally, and the same thing is repeated all around. Now we are working on the bare area of the stomach, where there will be attachment of peritoneum to the undersurface of the diaphragm, which needs to be released carefully, and we can appreciate the anterior vagus running over the esophagus. Once the peritoneal attachment at the level of bare area of the stomach is lysed, then we come on the posterior aspect of the hiatus, where we will try to identify the junction between the right and left crest, and from there we will try to slide our instrument along the left crest, so that we'll be able to detach the phrenoesophageal attachment on the left crest. As you divide like this, you will be able to create a retroesophageal window. Once you create a retroesophageal window, it is easy to pass a umbilical tape around the esophagus in order to tie it around the OG junction. Now we are seeing through the retroesophageal window. We are trying to mobilize part of the stomach through the retroesophageal window, and then again we are coming back to the hiatus in order to release the adhesions. So main structure which needs to be protected are anterior and the posterior vagus. So you have to protect these two vital structures while mobilizing the esophagus. You can appreciate the posterior vagus, which is close to the harmonic scalpel. Now you can appreciate we are tying the umbilical tape exactly around the esophagogastric junction. This will help in giving a better traction to the esophagus, so that we can mobilize the esophagus better. And the other use of having the umbilical tape around the OG junction is, while doing the fundal wrap, the fundal wrap should lie above the umbilical tape, so that we will not do the fundal wrap accidentally around the cardia of the stomach. And this is the completely mobilized esophagus, except for minimal attachment. The dissection is completed, and you can appreciate the anatomy beautifully: right crest, left crest, and a large retroesophageal window. So we try to release few attachments between the fundus of the stomach to the undersurface of the diaphragm, and sometimes we release and divide few short gastric vessels also through the window. but majority of the short gastric vessel division is done on the left side. So you catch hold of the stomach and retract it onto the right side and use other instrument to catch hold of the gastrosplenic ligament and lift it, so that we will be able to divide the gastrosplenic ligament and you can enter into the lesser sac again. And you can see the short gastric vessels which is running in the gastrosplenic ligament, which is sealed carefully and divided by using harmonic shears. And the same dissection is carried on the cranial side. And as you go close to the upper pole of the spleen and the fundus of the stomach, both structures will be adherent together, and you have to be very careful not to injure either the stomach or the spleen. And sometimes you come across a retrogastric vessel, which is the branch of splenic artery that needs to be divided. This small bleeding is being arrested and the dissection is almost complete. You can appreciate the entire left crest is free from attachments. Now we are holding the umbilical tape and retracting the esophagus downward and anteriorly, so that the hiatus is exposed better, and we use a non-absorbable suture in order to approximate the right and left crest of the diaphragm. While doing the suturing, you have to make sure that you are not injuring the aorta or the left inferior phrenic vessel, so that you will not have any bleeding. Normally for crural repair we need 2 to 3 sutures. Sometimes we may need extra also. Sometimes if the hiatus is very wide, we may need to use 1 or 2 sutures extra. Sometimes if you need too many sutures, we place 1 or 2 stitches on the anterior aspect, so that there will not be any change in the course of the esophagus. This is the third stitch. You should not strangulate the muscle. Our aim is to bring the right and left crest together, so that there will not be any herniation. And you should also leave a significant amount of space between the esophagus and the crural closure, so that there will be adequate space for the food bolus to come down, and patients should not have any dysphagia in the post-operative period. You relax the esophagus and make sure that it is exactly filling the lumen. And now we are trying to bring the stomach from the left side to the right side, and a few attachments are released, and we hold the anterior wall and the posterior wall with 2 instruments, and we try to do a Susain maneuver, and you can appreciate the total fundus is free from attachments. It is lying very comfortably, and we start doing fundoplication. The first stitch is from the fundus to esophagus, again to the fundus on the right side, and it goes back again, so that it is forming a U stitch, and the remaining sutures will not be like U stitch, it will be like a regular suture. Only the first stitch we place it like a U stitch. You can appreciate we have made a U stitch and we are tightening it. And once this fundal sutures are made, you have to introduce your instrument between the fundal wrap and the esophagus in order to check whether you have got a good space between the fundal wrap and the esophagus. The aim is to create a short and floppy Nissen fundoplication, not to have a tight wrap which can cause significant dysphagia and bloating in the post-operative period. You can appreciate we are introducing the instrument between the esophagus and the fundal wrap, and you can see a good space is there. It is not tight, you have not done any tight wrap around the esophagus. And this is the third suture between the fundus to fundus that will complete the fundal wrap. And now next our aim is to fix the fundal wrap to the crura so that it will not migrate into the mediastinum. So we take a bite from the fundus to the esophagus to the phrenoesophageal ligament on the left side. Once this is done, we'll make another stitch between the fundal wrap and the crura. This again will prevent transmigration of the fundal wrap into the mediastinum. We very rarely use prosthesis to do hiatal repair. Most of the time it can be managed by using sutures alone. This is the completed procedure you can appreciate. And after that we will deflate. Normally the patient will stay in the hospital for 1 day. We'll start on oral fluids on the next day, and we'll tell the patient to take soft diet for 2 to 3 weeks. And we have to inform the patient that in the initial post-operative period there will be some transient dysphagia due to edema, and that will recover after a few weeks. So this has to be informed to the patient prior, otherwise patient will have some anxiety. Thank you very much.